Thank you for coming to our session today. We have ADPKD in focus, guiding practice through the latest guidelines. With that, I'm going to start the session. My name is Edgar Lerma. I'm a clinical nephrologist. I'm based in Chicago. We are going to talk about ADPKD in focus today. So a lot of you in this room probably are familiar that we have had the latest KDIGO guidelines release this year on ADPKD, on the evaluation, diagnosis, and management. These are my disclosures. So our learning objectives for today, we will talk about the history of some understandings of ADPKD and the development of the guidelines. We're not going to get a deep dive into that. We will gain an understanding of the epidemiology, diagnostic and screening and monitoring practices, as well as underlying genetic pathomechanisms of ADPKD. And of course, we will try to familiarize ourselves with the various complications that arise from having ADPKD and management options. So we have two wonderful speakers today. Our first speaker is Dr. Neera Dell. She is a professor of medicine in the Division of Nephrology and Hypertension at Mayo in Rochester. She received her MD and PhD from Tufts, so locally, right? And residency and fellowship at the Beth Israel Deaconess Medical Center here in Boston. Prior to coming to Mayo in 2023, she was instrumental in developing the Yale Inherited Kidney Disease Practice and was the director of the Yale Center of Excellence in PKD. She is a member of the Scientific Advisory Committee for the PKD Foundation and the past co-chair of its Center of Excellence Advisory Board. She is currently the director of the PKD Center of Excellence and associate director of the Mayo PKD Center in Mayo Clinic in Rochester. She will be talking about the guidelines in practice, focusing on epidemiology, diagnosis, screening, and genetic insight. Our second speaker is Dr. Fuad Shebib. He is a nephrologist and assistant professor of medicine at Mayo Clinic in Florida. After doing his medicine training at St. Elizabeth, again, a local, and fellowship in nephrology at Mayo Clinic, he became a Mayo Clinic scholar for a couple of years, and he developed his research program under the mentorship of Dr. Vicente Torres. He also did a postdoctoral fellowship in molecular nephrology and ion channels with the Alper Lab. His clinical and research focus is on the advancing of medical care and preventing kidney failure in patients with polycystic kidney disease. His research examines the molecular mechanisms that lead to cyst formation and explores targeted treatment options, novel targets with promising therapeutic potential in ADPKD. He is currently the director of the PKD Center of Excellence at Mayo Clinic in Florida, and we will hear from them shortly. So I just want to share this one paper, which is nicely written. If you want to dig into the history of ADPKD, so there's this nice paper that's written about how it was first described. Whenever we talked about the history of ADPKD, the name Stephen Batory comes up. He is one of the Polish kings, and he had actually an interesting story. He died in the 15th century, and this is sort of his symptoms prior to his death. And interestingly, there's a nice story, there's a nice depiction of how this happened, and this was written by Dr. Torres in NDT. And basically, after a hunting event, he had some trauma, and eventually he died shortly thereafter. And when they extracted his internal organs, the surgeon described the cysts in the kidneys as large, like those of a bowl with an uneven and bumpy surface. So, of course, scholars try to interpret this in the context that this is likely polycystic kidney disease. Now, on the 400th anniversary of King Stephen Batory's birth, the authorities at Krakow Medical School invited a group of medical specialists and historians, and they looked at the history of how this happened. And after this meeting, they concluded that the most likely cause of the king's death was polycystic kidney disease and uremia. So we know that PKD is the fourth leading cause of kidney failure, but it did not attract the interest of physicians until the 18th century. In the late 18th century, Matthew Bailey noted that these cysts were vesicular and were different from hydatid cysts. He called them false hydatids of the kidneys. And in 1888, Felix Lejar used the term polycystic kidney disease for the first time. And he stressed that these cysts were bilateral and caused clinically identifiable symptoms. So by the end of the 19th century, the basic clinical signs and genetic basis of the disease has been better defined. However, it takes another several decades before we can understand the inheritance pattern. So in 2014, the KDIGO conducted a controversies conference, and this was in Edinburgh. So the controversies conferences with KDIGO tried to determine if there's enough evidence in the literature that warrants writing of a guideline. And so 11 years from that meeting, we have the 2025 KDIGO guidelines, which is now available. So with that, I want to welcome our first speaker, Dr. Nira Dal.
All right, thank you very much. It's my pleasure to be in Boston, and thank you, Edgar, and to the NKF for having us. I thought I would pick up from that theme and talk a little bit about how KDIGO came to the guidelines that they came to. If you read them, they're very comprehensive. And let's make sure I can advance the slides. My disclosures. All right, first talking about ADPKD. So maybe we know a little bit more than we did when we were doing autopsies on our royalty. But so what this disease is inexorable growth of cysts. And at first there is preservation of renal function because there's hyperfiltration in the remaining preserved parts of the kidney. But then there's a steep decline as you pass that point of no return in terms of hyperfiltration capabilities, and there's loss of renal function. And as this is going on, patients may be developing concentrating defects, may be developing high blood pressure, dull pain, discomfort, proteinuria, and then have flank urologic events, cyst rupture, bleeding into a cyst, kidney stones. We know all of those things are more common with the kidney presentation of ADPKD. And there are a lot of the data that went into the KDIGO guidelines. It is a very, very comprehensive review of what's in the literature to date. There are 10 chapters that were there. This is all evidence-based review. It was written and then made public for public comment for about a month, and then rewritten based on those public comments, and then finally published in 2025. And there are two sorts of guidelines within KDIGO. So the first is a graded recommendation. This has the strongest amount of clinical evidence to support the recommendation. And you'll see there are only 18 recommendations, actual evidence-based guidelines within KDIGO. There are 142 practice points, and practice points are the consensus of the group of experts, international experts that were convened to talk about KDIGO. So it is a disease that's rare and a disease that's been studied a lot, but not in a global way. And so I think we're still in the thinking about how to develop good data to study this disease. ADPKD, as you all know, is a systemic disorder. So there are cysts in the kidneys, but also in the liver and in the pancreas. There's potential for bleeding or infection in these cysts. There are kidney stones, there are mechanical complications due to cyst size. Patients are at higher risk for cerebral aneurysm. Dr. Chabib will take us through that in a little bit. These patients are more at risk for abdominal hernias, for cardiac disease, particularly some valvular disease, so mitral valve prolapse or aortic root enlargement or left ventricular hypertrophy. Patients, particularly post-transplant patients, can have a higher risk of colonic diverticula, and there can be male infertility. And here you're just seeing an image of kidney cysts in the left kidney and then a few large cysts in the liver. The genetic prevalence is higher than what we think we see in the clinical population. So the genetic prevalence is about 9 in 10,000 or about 1 in 1,000. And de novo disease, where there's no clear evidence of history in either parent, is about 10 to 25% of all patients. Hypertension affects 70 to 80% of patients, and about 50% develop kidney failure by the age of 62. Disease severity can be quantified by Mayo imaging class, and we'll hear about that, with Mayo 1C, 1D, and 1E associated with the highest risk of progression. And then patients who have atypical imaging, so Mayo class 2, are at lower risk of progression. And there's a lot in the first chapter of the guidelines about genetics, and I will focus mostly about what's in that first chapter, diagnosing ADPKD. And ADPKD is still a clinical diagnosis, so it's still your assessment of the kidneys after looking at the clinical imaging. So ultrasound is a perfectly good way to diagnose ADPKD for those with a family history. And with a family history, someone who's age 15 to 29 who has greater than 3 cysts would meet the definition for having ADPKD. And as patients get older, they have more cysts that form with ADPKD, and the guidelines say you must have more cysts in the kidney to meet the criteria. So this has been around for a while, and this is unchanged. The way this has been evolved into clinical practice is like this. If the person meets ultrasound criteria, then you can make the diagnosis of ADPKD. If there are equivocal or atypical features, then you may want to get either a kidney MRI to see if there are more cysts than maybe you're expecting, or if there are liver cysts or some other feature that helps you make the diagnosis. Or dissuades you from making the diagnosis. If you see liver fibrosis, for example, you might think of another disease. Or you could go down the pathway where instead of looking at an MRI, you get genetic testing. And there's a lot about genetic testing in the new guidelines. So if the genetic testing takes you to a diagnosis of ADPKD because you hit one of the PKD genes, then you've also diagnosed PKD. Otherwise, you may consider additional imaging in the future to see if then, in looking again at the patient, they meet criteria, or you think that enough new information has emerged to make that diagnosis. Okay, and the reason that even if you've made the diagnosis of ADPKD, you have a typical family history, you might want to consider genetic diagnosis is because of this. Sometimes there are mimickers, right? So the clinical image looks the same, but the cause of that disease is different. So if you look at the first 3 panels, so the first 3 panels, A, B, and C are the things, that we would expect, right? So A is PKD1 truncating variant, very severe disease. B is a PKD1 non-truncating variant, and C is PKD2. So those are all looking about the way we would expect them to look. But if you look at the next 2 panels, so panel D and panel E, Panel D is actually a hypomorphic or ultra-low penetrant allele for PKD1. And if you see that image where it looks like normal-sized kidneys and a couple cysts, you may say, that's not PKD. And that would be a fair clinical diagnosis, but it's not the genetic diagnosis, right? So that's where some of this discussion starts to become important. If you look at the next panel, at panel E, again, these are normal-sized kidneys with a few cysts, and that's due to a gene called GANAB, which can sometimes look like ADPLD, polycystic liver disease, or look like ADPKD. And then the others are just showing you that that's true for liver cysts as well, that some of these genes can look more like they cause only liver cysts or predominantly liver cysts, and some look like they cause predominantly kidney cysts. So now the nomenclature includes that genotype if known. So if you know someone is a PKD1 variant, you would call them ADPKD-PKD1. And it just adds sort of our to our knowledge and understanding of how to manage that patient. So the testing for cystic kidney disease is also increased a bit. So it used to be if there was very early onset of ADPKD, which is typically a disease in adulthood, but if you see it in a young child or if you see it during in utero development, you see the baby has kidney cysts, then you may do genetic testing early. You may do it in the transplant setting if you're evaluating a young donor. You may do it if there's atypical features in the imaging or if there's no known family history because you want to make sure you're dealing with ADPKD. So that was pre-KDIGO what we did. And then there's an expanding indication now for genetic testing, which includes what if you see just a very limited number of cysts? Should you be testing for that or not? Is that PKD or not? If there's a lot of variability within a family, so we know that in about 10% of families, there can be extreme variability, someone with very early onset disease and someone with very late onset disease. But still, if you see that, you may want to think about what's going on in that family. Does the one with very early onset disease have what we would call a genetic modifier, something that's pushing the disease to look more aggressive? We talked about the atypical features. If there's discordance between what the imaging shows, the kidneys are not very large or cystic, but the person is losing kidney function very quickly, it's reasonable to get genetic testing in that case because you may have another disease. You may have ADPKD, for example, and not PKD. If you have very early onset disease, we talked about if people simply want to know what their genotype is because that helps with prognostic information, all of these may now be reasons to get genetic testing. And the spectrum of what is in ADPKD has changed. So we all know our friends in this group are PKD1 and PKD2, the two genes that account for about 90% of all ADPKD. But there are now 8 genes in this spectrum. And the remaining genes, the next most common is IFT140. I'll show you that. It has a very unique sort of imaging presentation, so if you see it, you won't miss it. The other ones here, ALG5 and ALG9, cause milder disease with relatively slow progression to end-stage kidney disease. DNA JB11 causes bilateral kidney cysts, but the kidneys don't get enlarged, and so it's a little bit different on the spectrum. GANAB we talked about, and then there's one that we see predominantly in young adults or children, NEC8, which can also cause very large kidneys and severe disease. So within the spectrum of PKD1 or PKD2, truncating PKD1, that's the light blue, causes almost all. That's 50% about of all of the genotypes that we see. Non-truncating PKD1 is the next most common, and then PKD2. And then you can see there are a whole variety of genes that start to make up the remaining basket. And the one we think is likely to be gene number 3 is IFT140. If you know the genotype of a patient, you can also use that for determining the risk of progression with using something called the ProPKD score, which is the sex of the patient, hypertension before the age of 35, a urologic event before the age of the 35, or the mutation type. And this gives you a risk estimate of kidney failure. In the interest of time, I'm going to skip this difference between genotyping and imaging and just move on to show you what IFT140 looks like. So IFT140, there are predominance of exophytic cysts, these cysts that sort of pop out of the kidney, and this is associated with a milder disease. 90% of these patients are the atypical imaging, class 2A patients, who have a later age of diagnosis, later age of onset of hypertension, and less loss of kidney function. This is the list you look at for fun. So there are a lot of genes that mimic ADPKD, and some of them are listed here. So the most important, because they're the most common, are the collagen genes. So call4, A3, A4, and A5 can cause kidney cysts, and also are the most common sort of next bucket of kidney diseases. So those are important to know. And then a lot of other mimics for things that cause cysts. This, I think, may be my last slide. Just if you start thinking about these genes and then think about what percentage of the population they are, and then also something we think about from a genetic point of view, which is the penetrance of these genes. What you see is PKD1 and PKD2, which cause most of the PKD, are highly penetrant. So most people within our database get coded with having PKD and have at least 10 cysts per kidney. The other genes, so ALG8, ALG9, the penetrance is less, 50% and then 30%. And then the IFT140, 172, the penetrance is much less, meaning you can have that gene, but you may not have a phenotype that looks like that anyone would recognize as ADPKD. All right, and then just my very last slide is that in a family member, ultrasound or MRI can also be used to exclude ADPKD. So with MRI, less than 5 cysts in a patient would help you exclude the diagnosis of ADPKD if you wanted to use that for kidney donation. And with that, I'm slightly over time, but thank you very much.
All right, thank you, Dr. Dahl. Thank you, Edgar. Thank you for the NKF for organizing a PKD session. We appreciate that. And thank you all for being here. So my job is to kind of put together, I think 600 pages into a 20-minute talk in terms of management. So hopefully I'll put kind of what's new. There's not big surprises in the guidelines, but there are some interesting things. So here are my disclosures. So I don't need to repeat the slide, but definitely to show you that there's high phenotypic variability where there's a lot of patients who reach kidney failure early, but some reach later on. So we think 50%, maybe in the 60, 62, 65, depending on the cohort. High phenotypic variability, almost all males would reach kidney failure at some point. By age 80, almost 100%. Females, maybe a little bit, 5 years difference in terms of onset of ESRD, with females being milder. You heard a great talk with Dr. Dahl about the genetics. So now, if you see patients in your clinic, it's important to be very specific, right? So you're gonna say ADPKD dash if you know the genotype, and hopefully you're proponent to getting genetic testing and characterizing your patients as accurate as possible. You can say either PKD1 or PKD2. And the reason why we need to be more accurate is kind of becoming, kind of characterize our patients, but also if we're going to go for big trials and help our patients for new treatments, we need to be as specific as possible. But it does give you a lot of information for your patients. So truncating is the most severe, PKD1 truncating, but then within the non-truncating, there could be two different subtypes. One is a little bit more severe than the other, PKD2 being the less severe. But also it's important to know that not all patients with PKD are true ADPKD, PKD1, PKD2. They will still have the diagnosis of ADPKD, but for example, IFT140 has this unique phenotype, and they do much better than even PKD2. They will end up with some CKD, but almost never ESRD unless something else is going on. GANAB is a very mild PKD form. Mostly there's more liver cysts, and usually they're pretty mild, even like less than CKD, so GFR more than 60 typically, unless there's something else going on. DNA JB11 is tricky where the kidneys, it is ADPKD because it's polycystic kidneys. The kidneys are not enlarged. And you could have normal GFR up till your 50s or 60s, but then later patients would reach kidney failure. So they will have family history of PKD. You look at them. If you don't look at the images, you're not going to be able to suspect DNA JB11. So this kind of to tell you that genetics is important to obtain in our patients. Now, so what causes patients to be a little bit more severe than others, given that high phenotypic variability? Of course, having a PKD1 mutation is the most severe cause, but there's a lot of downstream effects that could be affected by multiple things. So factors that could affect severity, we talked about the gender, males being more severe. If you have excess weight, that's connected with more severe disease, cyst bleeding, cyst infections, and then the PKD1 truncating, of course. So how do you put that together in your clinic, right? You're not going to be able to track all this back. It's important to understand how do you do the methods of assessment of risk of progression, right? So we talk about risk of rapid progression and then slow progressing, right? So you can have a pro-PKD score that Dr. Dahl mentioned that is based on clinical data as well as on genetic data. And that gives you kind of the probability if the score is 7 or above that these patients would reach kidney failure by age 60. There's other things such as looking at the GFR rate of decline, or at time of when you're seeing this patient, what is their GFR? So if they're 60 years old with GFR of 70, you know that already they're not rapidly progressing, right? So it's important to put the GFR, the age, the genetics, the imaging together. But imaging is a big part of how do you assess your prognosis. There's the total kidney volume, which is a prognostic biomarker. And there's the age-adjusted total kidney volume with Mayo Imaging class. And then that also gives you a prediction of how fast the progression is going to be. So the KDIGO guidelines recommend to use Mayo Imaging class to predict the future decline. And actually it got a very high, so it's a recommendation of 1B, which is the highest, by the way. There's no 1A in the KDIGO guidelines. And then as a practice point, they say don't use MIC unless it's PKD1 or PKD2, because the rest you're not going to be able to use the Mayo Imaging class, right? They could be atypical, or they could be still typical, but for example, DNA JB11, you're gonna get Mayo class 1A, but you know that doesn't fit the predictions, right? 1A would never reach kidney failure. DNA JB11 with 1A, they would reach kidney failure. So it's important to start kind of getting that nuance and be familiar with the imaging phenotype in your clinic. So we put this kind of as a summary in our recent review. So use the Mayo class, use the pro-PKD score, genetic data, GFR rate of decline, and then kind of stratify into slow, intermediate, and rapid. And then based on that, that's going to change your management. For the most part right now, if they are at risk of rapid progression, we have only one FDA-approved treatment, tolvaptan, but hopefully more in the pipeline, many more hopefully. And everybody should get the basic optimized management, so I'll kind of touch on that through my next slides. So in terms of indication for tolvaptan, there's kind of two schools of thought, the US consensus or guidance and then the European. And you know, it was a little bit different in terms of how you define rapid risk of rapid progression. And then the KDIGO guidelines did a great job in kind of merging this together and at least have some sort of a consensus on that. So the recommendation is to use tolvaptan for patients with ADPKD who are at risk of rapid progression with eGFR of 25 ml or more. And then the risk of rapid progression was defined as reaching kidney failure by age 60, which was the average in multiple cohorts. We are advocating for age of 65 because we think 60 is still very, very young. So Mayo imaging class 1C, 1D, 1E, or historical rate of decline of 3 ml or more. But there's a caveat to those. So for Mayo class 1C, the guidelines want you to kind of understand that there's a little bit of potentially some are slow progressing, especially if they're close to the 1B. Right? So for these patients, they want you to add a little bit more information, like the pro-PKD score, maybe a family history that's more suggestive of a PKD1. At time of when you're seeing them, they already have a little bit of reduced GFR based on that age-calibrated GFR, and then maybe a GFR rate of decline more than 3. So have something more for the Mayo Class 1C. And then if you're looking at the GFR rate of decline, you have to make sure that it's all PKD related and there's no acute kidney injury, there's no diabetes, there's nothing else that can explain that GFR rate of decline, right? So you just want to make sense that this is severe PKD, you need to slow it down and treat them. Now in terms of titration, nothing new there. So you start with 45 milligrams in the morning, 15 milligrams 7 to 8 hours later, you titrate up. And in the KDU guidelines, they went with the European style, which is titrate up to tolerability and don't use urine osmolality. You can still use both. I think it's just a practical preference. And usually the devil is in the detail on how you practice that in your clinic, so we can talk about that later. But for now, titrate to tolerability. So basically, at least every week, so you can go up to 60-30 or 90-30. If they don't tolerate that, you go back down the dose. Also, if they don't tolerate 45-15, you can go down to 30-15 or 15-15, or sometimes even start 15-15 if you think there's some other medications that could contribute to polyuria. How about patients who are age 56 to 65? That's still a controversial area, and when it's controversial, they will tell you shared and individualized approach, which means you do what you want to do, right? So I will tell you what I do, based on some data that we put together. So, I mean, what does it mean, shared decision, right? So you have to tell the patient in front of you, you think, or I think as a provider, that you're going to benefit from this, and those are the risks, and can we both agree that the benefit is better than the risk, right? So for patients who are 56 to 65, and if you know exactly they are rapidly progressing, so by that time they should be an evidence of rapid progression rather than the risk, which means you start seeing the GFR being lower. So we did the post-hoc analysis on patients in the TEMPO trials that received tolvaptan, and then we matched them based on their age and GFR, and that was the difference between that and REPRISE study, and we showed that patients who have CKD stage 3 or 4 and already proven that they have a GFR rate of decline of more than 3 ml per minute per year, they will benefit from tolvaptan, and the difference is close to what you usually expect, which is 1.66 ml per minute per year, and that's beneficial for tolvaptan. So for these subset of patients, I would say yes, go for it. We did put it together in the KDOKI guide work group that is hopefully being published soon, and so this is the usual 18 to 55, GFR more than 25, Mayo Class 1C through 1E. For the older patients, you need to have also the Mayo Class plus the GFR rate of decline, and their GFR should be less than 60, because by that time, if they're 56 and GFR is 60, they are slow progressing, so you should not treat them with tolvaptan. Then you continue tolvaptan until they reach kidney failure, so either dialysis or preemptive kidney transplantation, so don't stop if their GFR drops below 25, even if the insurance tries to push you for that, you have to push for that. And then if they don't tolerate or they don't want to be on tolvaptan, please refer them to the closest clinical trial. We need all of your patients with PKD to go into clinical trial to really help them get more options and hopefully combinational therapies in the future. Alrighty, so next is pain management. Pain is a big deal for patients, and I'm sure if you've seen enough PKD patients, you will hear they have quite a high tolerance for pain. So they wake up and they have some sort of pain that most of us would not tolerate, but for them it's normal. The KDIGO guidelines did a great job in involving patients, and they kind of got with the providers and the nephrologists different ways of doing this shared decision-making in terms of how do you treat pain. So you see here the non-invasives, meditation, Alexander technique, heat pad, ice, so whichever things that can help them. Then you start going into the non-invasive therapies, acupuncture, TENS therapy, and what have you. Then you can go into spinal cord stimulation, cyst aspirations, foam sclerotherapy, celiac block, renal denervation. So I just want to show all these that there's options for patients, and if you don't have that in your local area, make sure you send them to either a center of excellence or another area where they do these procedures to help them out. But for sure, listen to them, and they definitely have a true pain, so don't brush it off, please. Now, if they do have kidney infection, kidney cyst infection, also there's this nice guideline that showed usually you start suspecting that if they have a fever, abdominal pain, acute abdominal pain, and high serum CRP. And then if there's other causes of these symptoms, then you kind of treat that. If not, you start looking to think about, is it a cyst infection or not? Okay, so you need 2 in 2, basically at least two things from here in 2 different categories. So whether in the clinical factors as a pain, symptoms, or microbiology, or kind of the findings on the imaging. So try to work with your radiologist if you have that suspicion. You can use indium scans as well, or PET scans if needed. If you confirm the diagnosis of cyst infection, you should treat for a longer period of time, which is 4 to 6 weeks, and try to work with your infectious disease group to decide on the antibiotics. And then in terms of nephrectomy, also it's still controversial. So the KD guidelines says if the risk outweighs if the benefit outweighs the risk. So those are the indications, the usual, right? If they have recurrent infections, bleeding, pain, kidney stones, cancer. So it's not automatic that we take these kidneys out. They do recommend more of a unilateral, although this is regional preference. We do bilateral, for example, for us. There's also some sort of consensus that it's better to do it either at time of transplant or after, because of the risk of sensitization. If they do it before, they get a lot of blood transfusions, and you might risk of sensitizing them more. All right, so PKD is definitely beyond just the kidneys, and it affects a lot of other organs. So we're going to look at liver, brain, and heart. So for the GI, just kind of to give you a quick idea, you could see congenital hepatic fibrosis, although it's more common in ARPKD. You will see pancreatic cysts, and that might freak out the patients, the radiologists. We see it up in 10% of the cases. Usually it's benign. You just need to follow up with that. Splenic cyst is part of that, of course. Colonic diverticulosis is also more common in PKD, and abdominal wall hernias. So what kind of complications come from liver cysts, right? So it's quite common. Almost everybody would have some sort of liver cyst, but only 5% would have severe polycystic liver disease. So it's not very common to have a lot of complications, but when it happens, they kind of feel alone, because usually the nephrologist takes care of that, or the PKD nephrologist, rather than the hepatology group. So symptoms could include shortness of breath, fatigue, pushing on the abdomen, so on the stomach, so mostly decreased appetite, early satiety, malnutrition. But also you could have cysts obstructing the hepatic veins or obstructing the bile ducts. So you could have a little bit more complications there. We divide patients into Mayo type A, type B, type C, or type D, or Schnell-Doerffer Mayo type. This is based on the anatomy and plus or minus the symptoms, but mostly the anatomy. So if they have, this is the typical form where you just have few liver cysts. It doesn't cause a lot of issues. You can have a little bit more severe where there's a few very large cysts, and these patients are good candidates for cyst aspiration or fenestration. Type C is very good for partial hepatectomy, which we'll talk a second about. And then type D, you have almost everything is cystic, so the best way is to go for a liver transplant. So this is a review by Dr. Hogan from Mayo Rochester, saying that if you have no symptoms, which is the more common, then you do mostly nothing. But if they have symptoms and they are candidate with very large cysts in these livers, so either we do fenestration or foam sclerotherapy. So using sotraticol, for example, is what we use. So the intervention radiologist would aspirate the fluid and then insert what we usually use for varicose veins and then burn the lining of these cysts. And you get, it's only for pain relief, and it's usually for a year and a half improvement in symptoms. There's not much morbidity, mortality in these procedures. If the patients have severe symptoms and decreased quality of life, definitely partial hepatectomy is an option. In Europe, they don't believe in this surgery. They think the liver is going to become cystic again. We did show them that after 20 years, it's sustained reduction. So usually it's kind of 60% reduction, and the rest of the liver just grows back, but it doesn't grow back very cystic, and the quality of life improves quite a bit. So but also it's important to use the surgeon that knows how to do this surgery. And liver transplant, of course, is an option if it's very cystic. And lastly, somatostatin analogs are known to improve liver cyst growth. So the liver cyst growth depends on age and estrogen. So for patients, female patients less than 48, they do grow quite a bit yearly. And then after 48, they don't grow as much. Males, there's very few patients that are males that have severe PLD. And here you see kind of the growth. Before 48, it goes up, and then it comes down. For males, there's very few in the severe area, but they still go up. So KDIGO kind of recommends to, if you have young females with kind of what you start saying, moderate polycystic or severe polycystic liver disease, you should talk to them about adjusting the estrogen in their birth control, or if postmenopausal kind of estrogen supplementation. So it should be a discussion in your clinic. And then for PLD, we talked about octreotides or somatostatin analogs. Response can be variable. Data has been pulled from different trials, and it is effective mostly in young females, less than 48. If there's increased alkaline phosphatase, that could be a prediction for response. And then usually if there's no response after 6 months, you should stop. Typically, and thankfully, with severe polycystic liver disease, there's no change in the liver synthetic function, so they don't have liver failure. They might have a little bit of bilirubin elevation, but in less than 8%. Alkaline phosphatase and GGT can be elevated quite often. CA19-9 can also be quite elevated without malignancy. And so previously, in terms of transplanting these patients, it was very difficult to advocate for these patients, and you needed these criteria here. So at least Mayo type C or D, and then the hepatic, and plus one of these, hepatic decompensation, concurrent hemodialysis, and low GFR. Now the policy has opened up a little bit by removing the Mayo types and then by adding malnutrition and other things, sarcopenia as indication to get the transplant. Liver cyst infections are not common, but when they happen, they're a little bit tricky. So same symptoms, but maybe right upper quadrant pain. Also, you need 2 and 2, quite similar to the kidney cyst infection. Now, what's important here, if you already have a very large cyst that lights up on imaging, and you think that's infected, if it's in the guidelines, they say more than 8 centimeters in diameter. I usually use 5 centimeters in diameter. But for the guidelines, I'll go with the guidelines. So more than 8 centimeters, then you should drain it right away. If it's not drained by IR, you should go surgical drainage. And then if that's not the case, or if they're immunocompromised, they also should go for drainage right away. Otherwise, you treat them with antibiotics. If there's no response, you go for drainage. So that's on the liver. Going forward, I think I still have maybe 10 minutes. Good. Okay. So aneurysm is very important. So also we do become like mini radiologists, mini hepatologists, mini neurologists. So as a PKD, a systemic disease, it's important to have that connection with your colleagues in the center. So in this room, for example, most likely there's going to be 5 to 6 people with aneurysms that we don't know that we have the aneurysms. If we assume everybody here has PKD, almost 8 out of 100 will have that. And then if all of the people in this room have ADPKD and they have another family member with intracranial aneurysm, it's going to be all the way up to 22%. So you see here the percentages. The main thing we worry about is subarachnoid hemorrhage, which has high mortality and morbidity. You have to educate your patients about the thunderclap headache. So usually it's sudden, it kind of peaks within a minute, it's associated with nausea, vomiting. You have to educate them and their caregiver. This is an immediate trip to the ER. There's other things that you could see on imaging if you image enough, including arachnoid cyst, which is common, but it's usually asymptomatic, but it could cause subdural hematoma. So what are the risks associated? Like how do we know who's at high risk of aneurysm? Having ADPKD just puts you at high risk from the general population, but then within the ADPKD, there's also a high risk. So being female, older patient, having a family history is fourfold, and then higher TKV and advanced CKD. KDIGO did nicely put kind of which is a strong predictor and which is not. So family history is very strong, smoking, and then uncontrolled hypertension and PKD1 genotype are moderate. In the general population, having Japanese or Finnish ancestry or heavy alcohol use can put you at risk of either higher aneurysms or high risk of rupture, so keep that in mind. So there's this controversy. Do we screen everybody? How often do we screen? So do we screen every year everybody, or do we kind of do it more targeted? Kind of the guidance in the KDIGO guidelines was nice, I think. So there's advantages, disadvantages. The advantages of screening is you kind of detect these smaller aneurysms, and then you can intervene on them when it's needed, so you can prevent the rupture and the death of these patients. I think it's a very nice program. It allows adequate imaging follow-up, and then for most patients, maybe reassurance. However, also it can cause anxiety. So you have to work with your patient, what would they like to know? But also limitation would be you kind of detect these small aneurysms that are not gonna kind of grow with time, and you're just kind of adding more cost and concern for the patient. So, alrighty, well, so basically, the KDIGO guidelines recommend to screen patients who are at high risk, which is having a family history of intracranial aneurysm or sudden death of unknown etiology. So kind of ask about that. And then in terms of how do you screen, we get a brain MRA without contrast, so time of flight, brain MRA. Otherwise, you can do a brain CTA. Mostly, there's going to be anterior aneurysms. And then if they're posterior, they're more at risk of rupture. You should work with your neurology and neurosurgery and neuroradiology colleagues in terms of treatment and follow-up. We did put together this, so it's coming up in June. Basically, it's kind of a summary of what I talked about. And then if you do find an aneurysm, we recommend to get a repeat in 6 months, and then in a year, and then yearly after that. If you already see an aneurysm and it's more than 5 millimeter, or it looks kind of suspicious for, like has some features for rupture, you should kind of go straight for some intervention. And then if someone is at high risk and it's negative MRA, you would repeat every 5 years. If they're at normal risk, which is just having ADPKD, 5 to 10 years, but my neurology colleague says 10 years is too much, so I think I would go for 5 years for everybody. And again, that's not in the guidelines. They say 5 to 10 years in the guidelines. Now, when do you get echocardiograms? Not all the time. It's not a routine thing, only if you hear a murmur, uncontrolled hypertension, or some sort of symptoms that you need to kind of address as cardiovascular. You see all these other cardiovascular associations with PKD, but they're mostly on the rare side, and there's no recommendation to screen for any of them, unless there's a family history of thoracic aortic aneurysm. Blood pressure control, that's an important thing, so maybe I'm kind of finalizing now. So blood pressure control, based on the HALT study, there's a recommendation of 1D, so we recommend, but it's a weak, unfortunately, it's a weak evidence, not recommendation. And the target is for patients 18 to 49, with GFR more than 60, you target 110/75. Now, if someone is above 50, you target less than 120. That's based on the SPRINT data, and it's a 2C, so we suggest, and it's not super strong. And then between 18 to 49, actually, KDIGO did not mention these patients, so maybe I would go for 110/75 even. And then if they're between 110 to 130, individualized approach, so probably also treat. And then if you want to treat, favor ACE inhibitors or ARB. All right, so lastly, KDIGO also had a stance on other things, so including things that did not work in PKD, so mTOR inhibitors, statins, metformins, at least not yet, right? So they still want to see more evidence. Somatostatin analog for PKD, it's not recommended unless you kind of exhausted all your other options. They kind of kept that open. For the liver, you want to use somatostatin analogs if it's indicated. There's no evidence yet for SELT2 inhibitors, but hopefully in the coming 2 to 4 years, we'll have that data from Europe as well from the US in terms of safety and efficacy. They do not recommend ketogenic interventions, which is, of course, controversial in a way. And then that's my last slide. One thing that they also mentioned is the adjusted BMI. So that could become important at time of transplant if their BMI is borderline and you're kind of negotiating with your transplant program if they can be transplanted or not. So you tell them extract the weight of these PKD and PLD and then put back the normal weight of kidney. So you take the weight, you extract total kidney volume, right? So it's in liters, so you assume that's in kilograms. Same thing for total liver volume. And then you add back a normal kidney. So normal kidneys weight are 0.2 kilograms, and then liver is 1.3, 1.6 kilograms. So just kind of a notion, maybe someone who's stuck getting transplanted because of the large BMI. And thank you very much for your attention. Please visit our PKD Resource Center. It's a patient-facing education program. Thank you.
Thank you, Dr. Chibib and Dr. Dahl. We have now time for some questions. If you ask a question, please introduce yourself, where you're coming from.
Yeah,
and,
general nephrologist from Wisconsin. I have a question about tolvaptan coverage by insurance companies in the ages 55 and 65 outside the clinical trials, like in a clinical practice. What's your experience?
Say that one more time, the last part.
The insurance coverage for the tolvaptan
Yes.
in patients between 55 and 65.
Yeah,
Because
so
there is paucity of data. So what's your
so
experience?
refer them back to the KDIGO guidelines, which is now kind of what probably the insurance is going to use, and say, my shared and individualized approach is to treat these patients because based on the post-hoc analysis, they have CKD 3 or 4, GFR rate of decline more than 3, Mayo Class 1C, probably 1C or 1D, and tell them, as a provider, I think they're going to benefit from this. This is the post-hoc analysis. This is the KD guidelines.
They always want to supporting data. That's why now we have this. But up until this point, what was your experience?
Oh, my experience.
Yeah.
It's usually a peer review, and then I push back, and they say this patient needs the tolvaptan, and I push back a couple of times. If they don't, then I'll send them to clinical trials.
Okay, very good. Thank you.
Yeah, absolutely.
Thank you for that question. We have a question from the Q&A. This is for Dr. Dahl. Once you have obtained initial imaging for staging, do you or the guidelines recommend repeat imaging at some interval?
Yeah, so that's a really good question. We think that only the minority of patients change imaging classification, so it's a pretty rare event, probably about 10 or 12%. And so if you think like someone is right on the edge of 1B and 1C, for example, and there's a reason to change for staging alone, you might choose to do it after that. If someone didn't have hypertension, now develops hypertension, you might want to look at that. But otherwise, there's no specific consensus of restaging and when to restage.
Question?
Hi. Danny Haddad, a nephrologist. I had a question. I have one of my PKD patients that's been on tolvaptan for a while, and patients are always looking for something to help their disease process. So one of my patients told me about a supplement, Ketocitra. Are you familiar with it? And is there any evidence for any of these supplements that patients are looking for?
You want to answer this?
I gave my answer while a nice question was being asked. Yeah.
Well, there's a very nice preclinical, meaning on animal models, that Ketocitra, which is a beta-hydroxybutyrate. So basically, you're inducing ketosis by giving that, the ketogenic kind of medical food, right? The data is nice in animal models. In humans, it's still not there. The data is very scarce, and it's not enough to support us saying, yes, we need to give you this medical food. It's a little bit controversial in the field. If patients, so for example, I'll give you my expertise or my experience. If patients are already on it and they feel like they want to be on it, I'll support them. I'll make sure they don't have side effects from this, such as hypercholesterolemia or kidney stones, and kind of look at that with them. My impression is it does not work by itself. It needs to be also associated with very strict diet. And these diets, ketogenic diet, whether plant-based or non-plant-based, they're very hard to sustain and they tend to be expensive. Also, the medical food tend to be an extra cost. So for patients who are very eager to do a lot of things, I'm supporting them. I'm not going to oppose that, but I'm not prescribing this and tell them, please go and buy Ketocitra. Not yet, until we have the data in humans. Yeah.
Leighton James, Augusta. I have two questions. The first one is a patient who comes to us, incidental filing of PKD, bilateral amputation. How do you do the height-adjusted kidney volume?
I'm sorry, I didn't hear. I don't think we heard.
So the patient comes to us with, for elevated creatinine and some proteinuria. You measure and she has polycystic kidney disease.
Yeah.
Going back, she now tells me she has family history, but she didn't know that. But she has bilateral amputation. How do you do the height-adjusted kidney volume, total kidney volume?
Amputation. So basically
I don't know the height before her amputation.
Well, so you just assume probably, I usually use the average and then kind of average height of someone their age.
Okay. And the second question is, with the new guidelines, seeing that cyst is important, but one of the patients I have has a unique mutation that's only described in Japan and in South America. And she, with the Mayo classification, she is at 1B, sorry. I don't know if she's going to progress.
Okay, so I want to go back actually for a minute to the patient you presented before. We don't think that proteinuria should be a very prominent feature of PKD. So if the patient has high-grade proteinuria, it could be that it's one of those mimicking genes that looks like ADPKD but isn't. So the one that I would think of first would be those COL4A4, A3, A4, A5 genes. And so I would consider that if there is significant proteinuria. I don't know how much your patient had. The second question of, sorry.
Kind of a mild mutation, mutation in MSC.
Yeah, so you said that mutation was seen only in a couple, like in Japan and in Asia.
No, South America.
In South America. Is that mutation listed as pathogenic or likely pathogenic?
It's listed as likely pathogenic.
Okay. So that's pretty good evidence, right, that is a disease-causing variant. The 1B is just like the luck that they don't have a high risk of progression. So was it a truncating or non-truncating variant that was?
Truncating. And her father now has more advanced disease, but she doesn't. She's not, and she wants to start tolvaptan.
Yeah.
And the question is, do you start this early?
Yeah, so that's fair. So there's a discrepancy between that truncating PKD1 variant and the imaging. That's what you're saying, right?
Yes.
Sometimes in young women, we can see Mayo imaging class change after pregnancy, for example, or after with time, right? So I don't think any one of us would start her now, but she is at high risk, and she may be someone that you image again in 2 years or 3 years and see if she now meets that Mayo imaging 1C criteria. And then I would start her on therapy. So because she's starting at a better place, you may be able to start her treatment later than you would for someone else.
Sure. Yeah, thanks.
Thank you very much. So, we have one more time for one last question, and I'm going to ask this. The KDIGO guidelines did not mention anything about water intake. And I'd like to ask our panel, to comment about that and what they do in their practice. And by the way, I have to make a point that I think Fuad mentioned earlier that the KDIGO guidelines did not have any 1A recommendation. That is in the ADPKD guidelines. In the other guidelines, there are 1A recommendations. So, go ahead, Fuad.
So fair. Okay, so we both have a lot to say about water, I think. So KDIGO says that everyone should be encouraged to drink about 2.5 liters a day. That's because PKD patients develop stones, have concentrating defects, and so we think that good fluid intake is important for everyone with ADPKD. There are small studies that show if you have a very motivated patient who's drinking, being monitored very carefully, giving a lot of guidance, then that patient might be able to suppress vasopressin to the extent that they see some benefit in TKV. It's very, very hard to do. So the larger study that was published, most people were not able to sustain the fluid requirements to keep their urine osmolarities low consistently. And so we don't think that water alone will do it, right? We think that there's a true benefit to pharmacologic inhibition of vasopressin because it's very hard to be able to sustain the amount of fluid you need to drink to continuously suppress vasopressin release.
Yeah, very nicely summarized. Thank you, Dr. Dowd. I would just add, just decrease osmolar intake, particularly sodium. So the less osmolar intake, less sodium, the easier you're going to be able to suppress vasopressin with 2 to 3 liters. Hopefully you can push your patients to kind of do more and do it throughout the day. So starting from the morning, have kind of a way to track it until the night, and then if they wake up one time at night, kind of drink. So you need that sustained suppression, which is very difficult unless you're very kind of, we have a routine and you kind of push yourself. So similar to stones, where it's very hard to push your patients to do 4 liters of water intake, same in PKD. Yeah.
Thank you very much. I know there are a lot of questions on the submitted in the Q&A. Please approach our speakers for any of your questions that were not addressed. Thank you so much.